So we're going to continue our talk on rapid response. Again, my name is Michael Nanney with MedEd, and this module is the patient with chest pain. We're going to look at two conditions that are considered acute coronary syndromes. We're going to talk about some medications that are utilized during the acute coronary syndrome. And we're just going to talk about some signs of poor cardiac output. Again, let's just review the cardiac cycle. We see this all the time when a patient's either on their 12 lead or just a simple cardiac monitor. This is a complete cardiac cycle. Oftentimes, we adjust from leads 1, 2, 3, so forth. I adjust my leads on a single lead so that I can clearly see the PQRST. We know that P is depolarization of the atrium. And then it is repolarized, it's hidden in that R wave, but that R wave shows depolarization of the ventricles, and then T wave is pretty much the repolarization of the ventricles. So there's your complete cardiac cycle, just as a review as to what we're actually looking at and what is going on with cardiac issues. So what about cardiac output? So cardiac output is simply the blood ejected by the heart each minute. Average is about 5 to 6 liters. And that is at rest. We know that's going to increase if you're exercising. Cardiac output is influenced by heart rate times the stroke volume. So if you increase heart rate, you expect cardiac output to go up. You increase the stroke volume, or the amount of blood that's being pumped out, your cardiac output's going to go up. And of course, the same applies that if you drop heart rate, or if heart rate does decrease down where patients are very bradycardic, or that volume of blood is not there, then cardiac output could be low. Because you think about it, if you're hypovolemic, let's say there's a lot of bleeding going on, then that's going to correlate with the cardiac output being low, which is reflected in a blood pressure. So stroke volume, the amount of blood ejected by the left ventricle in one contraction. Okay, and we look at that as usually about 1 mil per kilogram of body weight. So what about poor cardiac output? Well, poor cardiac output can occur by the heart rate being too fast. So instead of getting this nice pump and we get the blood going out, the heart's being very efficient. If it starts pumping too fast, we get a decreased amount of filling time. So inadequate filling is going to cause us to have a poor cardiac output. Now, too slow. It's happening, the blood is filling into the heart, but it just doesn't pump it out very fast. So we're looking at a patient that's very bradycardic. Well, then we can expect, again, the blood pressure to be low because cardiac output is low. So a condition that is caused by a decrease in systemic perfusion secondary to myocardial dysfunction. So now we have poor perfusion through the system because for some reason there's a dysfunction. It is not a normal function of the heart to be beating very slow or to be beating very fast. And we're looking at those heart rates that are less than 60 or greater than 100. Now, true, there are patients that are very active who have resting heart rates of about 40. But the patient is not symptomatic, so that's why we are not concerned about it. And the outcome of having a poor cardiac output is that you get an imbalance between oxygen being delivered because not as much blood's getting out, so therefore there's not as much hemoglobin, so therefore there's not as much oxygen, so now the consumption has dropped. So that is one of the biggest issues that we have with cardiac output. Now we're not getting that good perfusion that is going on, especially that we know that we fill the coronary arteries during diastole, and if we have poor cardiac output, we are not going to fill those coronary arteries, and then therefore our patients could have chest pain. It's classic. We see it all the time. So what are some signs and symptoms of poor cardiac output? Well, we just talked about tachycardia. Heart's just going beat just really fast. Bradycardia, it's there, but it's just not enough to sustain a blood pressure. Ectopy. What about when patients have such things as preventricular contractions? You've got that extra beat in there. So now blood, do you get a stasis? Do you get like this turbulent flow? Another thing that patients may demonstrate is they may have weakness or fatigue. Well, if they're not getting good perfusion, the blood pressure may be low, their cap refill is going to be extended. So patients then are going to demonstrate this a lot of times with weakness and fatigue. They could also have dizziness and vertigo. Why? Because blood pressure is now decreased up to the brain and to the areas up there, so now the patient may demonstrate that. Obviously, poor capillary refill. We want capillary refills to be less than 3 seconds. It's easy to understand. Don't forget about that little aspect about body temperature. Patients that are very cold, you're not going to be able to depend on capillary refill. And of course, low blood pressure. They go hand in hand. High cardiac output, high blood pressure. Low cardiac output, low blood pressure. So that one's simple to remember. The other thing too is altered breath sounds. So if you've got a patient that cannot pump blood out to the body, it could be backing up. So a patient may start becoming fluid volume excess in their lungs. So what do you hear? You're going to hear coarse bronchi, coarse rales. If the blood pressure is not good, weak pulse. So instead of a 2 or 3 plus or even 4 plus, if you use a 0 to 4 scale, and it's important that you note that when you're saying a patient has a 2 plus radial pulse, note that you're using 0 to 4 or 0 to 2, because then now we know that it's normal or it's bounding. Look at skin color, edema. Patients that cannot pump blood, especially out to the lungs to get to the left side, is going to back up. Guess what? Ankle edema. All right? Jugular vein distension. Everything's backing up because what dumps into the right side there is those vena cavas. Okay? And then you've got poor urinary output. If blood pressure is poor, the kidneys are not filtering, so therefore decreased urine output. And what we're going to be looking at is basically about 1 ml per kilogram per hour now is what the trend is that we're looking at. So let's keep it really simple here. If you look at right atrium and right ventricle, then you've got this great pulmonary artery that goes over and it sort of comes back to the left atrium and to the left ventricle. Then you can see that if you've got problems on the right side, if you've got poor RV function, then you're not going to get blood pumping out to the pulmonary artery. Everything we know should be going in one direction, to the right atrium, right ventricle, through those valves, pulmonary artery, dumping back into the left atrium, left ventricle, out to the body. Well, if it doesn't move very well, then it's going to back up. So now we can understand why our patients have jugular vein distension, have ankle edema if there's a right-sided issue. If it's a left-sided issue, we're going to see left atrial pressures increase if we have a thermodilution catheter in there. Then it's going to be backing up into the lungs. And then therefore, we're going to start hearing patients with respiratory issues. So now it makes sense if you just look at this very simply. So what about chest pain? Now, not all chest pain is a threat. We have things what we call non-life-threatening chest pain. What about sort of like pericarditis, where we get elevations in all leads of a 12 lead? Okay, so we got that inflammation in the pericardial sac. Gastroesophageal reflux disease, we know it as GERD. So the patient says, oh, my chest hurts, it's burning. Well, they have GERD. So that's not a cardiac sort of issue there, so we don't need to worry about it. Patients can have chest pain with pneumonia. Patients say, oh, my chest has been hurting, it's been hurting for several days. I've done cough so much, I feel, I've got something in my lungs and now my chest hurts. Okay, that's again a non-life-threatening chest pain. We also have pneumothorax. Now, all right, non-life-threatening versus, now if it's small enough, they can have some chest pain, but if it's a true tension pneumothorax, then that is going to be considered life-threatening. Costochondritis, pancreatitis, all these can be reflected up into the chest area as well, and these patients can be uncomfortable. The main issue is, does patients demonstrate it as either pressure, aching, versus burning or sharp? Those are very key words that you want to document, because that is going to direct you more to a focused assessment, and then you can determine, do I have a cardiac issue or do I have a non-cardiac issue here? Again, your life-threatening chest pain is your acute coronary syndrome. Why? Because we're not feeding blood down to the coronary arteries. We're not getting blood down to the LAD, to the circumflex, to the RCA, and we know what that causes. Okay? Pulmonary embolism. Yes, especially if we start getting blood clots that are sitting in the pulmonary artery. We know that we're going to have ventilation perfusion mismatching occur. Aortic dissection. Tension pneumothorax, as I said before, this compresses all in the heart. We decrease our filling, our cardiac output drops. Therefore, we're not going to feed the heart. We're not going to get blood out to the lungs. Your patient is in a true emergency right here. Needle decompression is of the utmost importance and must be done rapidly in this situation. And of course, acute myocardial infarction, a STEMI, an ST elevation acute MI, okay, or ST elevation myocardial infarction is what we know as a STEMI. That is a life-threatening chest pain, especially if it's also more than one vessel that can be involved. Our patient can go straight into ventricular fibrillation or straight into a systole. So look at, as far as chest pain, use what you know on your EKG, PQRST. It's very simple to remember. So look at what brings the chest pain on. What were you doing when you started having chest pain? These are things that you want to know. What makes it worse? What makes it better? When did you first start noticing your chest pain? Because now you're going to paint the picture, as I keep illustrating or stating throughout this lecture. Look at Q. Q is for quality. I want you to describe your pain. Is it pressure? Is it sharp? Get it in the patient's own words. Let them, do not sort of lead them and say, is it sharp? Because they may say it's sharp when really they want to tell you something else. Ask them too, are they having any other symptoms? Because that is going to help you determine, do you have a patient that's having a cardiac event or a non-cardiac event? But you know, some patients too can have chest pressure but not have anything else. But often shortness of breath, weakness, diaphoresis, things like that, or I feel my heart skipping, things like that can be going on. The other thing too is region. Ask the patient where they're having chest pain, because the patients may present or may just say, I'm having chest pain, but then when they point to it, their chest is anywhere that it could be, from their clavicles all the way down to their stomach. It may be at their backside. They'll say, I feel it in my back here on the backside of my ribs. Those are the things you want to know. Is your patient, when they talk to you and you say, where is your chest pain? What does it feel like? And if a patient sits there and says, it's sitting right here at the middle of my chest and I feel like an elephant sitting on it and I am so nauseated and it's hard to catch my breath, those are triggers. Those are the red lights that go off, or I call them red flags that go up. Okay, so you want to ask those things. Again, become that CSI agent. Become very investigative when you talk about chest pains. Then talk about severity. Get them to rate their pain. Use the 0 to 10 scale. And if they can't say it, say, is it mild, is it moderate, or is it really hurt? Get them to do something like that. Use a known pain scale. And don't forget to also document or assess those nonverbal clues. Is your patient moaning? Is your patient gasping? Does your patient have facial grimacing? Things like that. You also want to note those things along with your chest pain. So don't look at the verbal and the nonverbal. Again, timing. When did it start? Did it come on suddenly? Did it slowly get worse over the past day? When was the first time? Things like that. And then ask about family history. Family history, smoking, diabetes, things like that are big factors that play into cardiac chest pain. And you want to know, especially when patients tell you, yes, my father and my brother and my other brother, they've all had to have cardiac catheterizations in their 40s. This is going to start really cluing you in as to more. This gives you a nice, good background about your patient. So what about acute coronary syndrome? It is a clinical symptom. Okay, it is basically telling you that you're getting myocardial ischemia. Now, 3 basic issues are occurring. Unstable angina, okay, or we call a non-STEMI, which we have non-ST elevation myocardial infarction, or do we have a STEMI, an ST elevation myocardial infarction? And we're going to look at those 3. So what are the causes of them, first of all? Well, coronary artery disease. You got patients with small blood vessels. They've got, a lot of little irregularities, little clots, so forth, little areas of stenosis that are in there. So the blood doesn't flow through as very well. And under times where the heart is demanding more, the heart just cannot deliver, so the patient's going to get chest pain because we're not delivering the blood to the area of the heart. Okay? Thrombosis. We've got those clots in there. We've got plaque that is sitting there that's narrowing the lumen of the coronary artery. So instead of it being nice and open, letting blood flow, we get these narrowed parts in there so the blood doesn't flow as well. We get vasoconstriction. Is that from a spasm that's occurring? Do we have a total occlusion of the coronary artery? And believe it or not, patients will sometimes demonstrate differently based on the coronary artery that is being occluded. And for example, patients who have right coronary artery occlusion often will demonstrate bradycardia, nausea, vomiting, and diaphoresis, just simply because a lot of times association with the vagus nerve. So look here. We've got a normal artery on your left, okay? So this is good. We've got good blood flow through there. And then we looked at a diseased artery on the right. We got a blood clot where we got plaque. So there's narrowing of it. Well, we know that if we narrow the lumen of something, the flow is going to be different. It's the same principle that if you do the thing where you bend your garden hose, the water decreases coming out. Well, you occlude a coronary artery, you're not going to get good blood flow coming out. So again, cardiac versus non-cardiac chest pain. All right, so you get chest pain that is not due to an underlying disease. They do heavy lifting and they've interfered with the intercostal muscles, so forth. They get trauma to the chest. They get, let's say they break some ribs. That's going to be non-cardiac chest pain. Swallowing a large piece of food. Patients may feel full and may have some pressure, but then when they'll tell you, I can't swallow, I got a piece of meat stuck. That is non-cardiac. So the history of what's been going on, the most earliest information, what were you doing, so forth, what does it feel like, you do an examination, and then get the 12 lead. A 12 lead EKG is basically supposed to be done about within the first 10 minutes of a patient's first complaints of chest pain. That is one of the standards by the ENA for the emergency room. But we want to get that 12 lead so that we can start painting that picture, because a lot of times that is going to help us make a diagnosis or start collecting information so that we can recognize things earlier and intervene earlier, and our outcome becomes better. That all refers back to the first module that we talked about at the beginning of this lecture. What about unstable angina? Okay, unstable angina, unstable angina, it's basically the same thing. This is chest pain that is unpredictable. It occurs at any time with patients. There is no set pattern to this. Plus, patients with stable angina say, if I sit down and rest, the pain goes away. But patients will say, now I sit down, or I drink some water, or I stop moving, or I take good deep breaths, and it's still there. They're finding it much more difficult to get the pain to go away. It is now starting to occur more often. They're now starting to have daily episodes, or in the morning and in the afternoon. They could just be sitting there watching a football game, like us guys like to do, and they could start having chest pain. Also, the chest pain seems to be longer. Some of them say, well, I'll have some chest pain, but it goes away pretty quick if I just sit still. Now it's hanging on. It's like it just doesn't want to go away. You look at an EKG or you look at the cardiac monitor, you get sort of this intermittent of ST depression. You're getting this a little bit of ischemia that's now occurring, and then it seems to clear up. As far as blood work, troponin, CK, CKMB kind of thing like that, those are not indicating anything because it's so transient and it's not there long enough to show us those elevations yet, because we're not getting injury, we're just starting out to insult the heart a little bit. So what do? So we need to do the diagnostic testing to rule out an infarct. So one thing that we could do is basically an ECG. We get an electrocardiogram. All right, so we look at that. And then we put patients on antiplatelet therapy. They look at that. As far as diagnostic tests, patients even may go to the cardiac cath lab to look at the coronary arteries. That could be one of the things to do. They can put them on Plavix, to help with that thrombus formation there. Managed lipids and cholesterol levels. All right, so that's it. It's diet. And we know it's very hard to adjust your diet when you're so used to eating a certain way. But we need to bring those down because we know that hyperlipidemia and high cholesterol levels will contribute to this. Also, blood pressure. We're going to use our angioconverting enzyme inhibitors. We're going to do those ACE inhibitors. We don't want angiotensin and first moving to angiotensinogen and raising blood pressure. Okay, we only want that to happen when we need that to occur. So we're going to give them ACE inhibitors, and those are going to be the drugs that end in PRIL. So PRIL is what you're going to see, and those are going to be your ACE inhibitors. Now, what about a non-STEMI, meaning a patient is having a myocardial infarction, but we don't have elevation quite yet on our 12-lead EKG. Okay, so that's what we're doing. It's still associated with cell death and injury of the cardiac issues. All right, so cardiac cell death and injury is still occurring. But what's happening to getting this intermittent coronary occlusion is the patient spasming, or is there a clot that occurred, and we see it on 12 lead by having some ST elevation or none, and then all of a sudden the clot then goes away. So then we could also get some ST depression that is showing that ischemia. So really we can't truly rely on an electrocardiogram. The ECG is just not a true indicator of what's going on. Cardiac markers are pretty much going to be negative right up front. You look at things like CK and B, it could take 8 to 12 hours later before they start seeing a change, or we start seeing a rise or start peaking. This is why a lot of times we'll see CK and B's ordered Q8 hours or Q6 hours times 3 for the next 24 hours. And because we're watching the trend on that, because we know as things progress, those markers elevate and then will slowly taper back off. Now with a STEMI, all right, so when we hear a patient is having a STEMI, this is a true ST elevation myocardial infarction. Okay, one or more of the heart's major arteries, LAD, circumflex, or the RCA, right coronary artery, is being blocked. Okay, this is a true emergency. And depending often on which vessel has been blocked, will also show you, or the patient will present with certain signs and symptoms. And because of the ST elevation on a 12 lead, where we see that 12 lead elevation will indicate to us which coronary artery is being affected. In a STEMI, you're going to get cardiac markers that are going to be elevated, especially troponin. And even though they're going to be repeated again in 3 to 4 hours, you're still going to get a troponin level. And you want that to be less than 0.04. But what you're going to see in the STEMI is that's most likely definitely going to be elevated, along with the CK-MB. Okay, so the CK-MB is specific for myocardial muscle. So again, the EKG correlates with the location of the blockage. So we're going to look for changes in the EKG or the ECG, however you learned it, and it's going to indicate myocardial ischemia. You're going to have elevated biomarkers, as they're known, and the symptoms are usually lasting more than 20 minutes. And often, too, most of these patients also have chest discomfort even at rest, versus unstable angina or angina where they may only have chest discomfort with activity. So with STEMI, even if the patient's resting and you got them on O2, they're still going to be having chest pain, because the problem is the coronary artery is now blocked. There's no blood going to the portion of the myocardium that needs to be fed by that blood supply. So let's first talk about troponin. Troponin is done routinely and is a very reliable source. It's a protein, is what we've learned. And it deals with the actin and the myosin complex in the muscle of helping with all the contraction and the work of the heart. It is only produced, it's a protein only produced by the myocytes, which myocytes are, cardiac myocytes are the cells of the heart. So it's very specific for heart injury. And we see up there that its normal is 0.04 nanograms per milliliter or less. And we repeat it in 4 hours if the first one is negative, because if the patient just suddenly started having chest pain and shows up, or just all of a sudden starts having chest pain on your unit and you get a troponin level, it may not be elevated. So you need to recheck that within 4 hours. So CK-MB stands for creatinine kinase myocardial B fraction. It's a specific marker, again, for myocardial damage. So just a CK can be elevated with muscle damage, but CK-MB is going to be reflective of the myocardial muscle damage. It is very sensitive in the 6 hours after the onset of chest pain, so in that first 6 hours, and it's usually noted or start being elevated usually within 3 hours of the chest pain. It peaks in 12 hours. So again, this is another reason why we want to do serial cardiac marker blood tests. All right, and you usually need 2 to confirm an MI. So, but if you get that elevation, you got an elevation in troponin, you've got the elevation on your 12 lead, especially with ST elevation, you're pretty much safe to say your patient's having a STEMI. All right, so let's look at the 12 lead, and I put this up here. This is really great because, as I told you, what is elevated on a 12 lead can reflect which coronary artery is being affected. And let's take one of the simplest ones to remember. If you think of 2, 3, and AVF for the right coronary artery, If you see elevation as you do in this slide, because look at your T waves, they're pretty high there, okay? You have right coronary artery most likely being occlusion. Now you can have a left circumflex, especially if it wraps around farther. Think about how the heart sits in the chest and where you're putting those leads. So if the heart is sitting in the chest and you start having elevations in leads V1 and V2, V3, V4, how is that? See, that is more ventricular. That is most likely what is being fed there, the LAD, left anterior descending. So you pretty much can say the LAD. If you've got elevation in things like such as 4, 5, and 6 that sits over on this side, well, what sits over here is your circumflex. And if you see that, then the elevations there can pretty much indicate that. And then if none of those, look at leads 2, 3, and AVF. You see the elevation, then you know it's right side. And plus, your patient often is going to be diaphoretic, they're going to be nauseated with right-sided infarcts, RCAs, and they're also going to be bradycardic. Okay, so there's another clue. And if you look at lead 2 at the bottom of that, you just see the ST elevation. So just looking at one lead does not give you an indication as to where most likely the ischemia or the occlusion has occurred. Okay, so here it is outlined again, and now you can see how it makes sense based on how that heart sits in the thoracic cavity and how you place those leads. That is just one of the ways that I have used to help me remember and to looking at 12 leads. All right, so look right here at this 12 lead, and you immediately see your ST elevations in V leads there, like 2 and 3, V2, V3 there, okay? And you're probably going to start seeing reciprocal changes over on the other side. So now you've got lead elevation in V2, V3. So that makes me think, because the way that is laying, because if I got V2 of left external border and V3 over here between V2 and V4, which should be at mid-clavicular, then I'm going to think, do I have an LAD issue here? Okay, so this is starting to give me an idea, and then that's going to make me think that my patient is more prone to having more ectopy, more blood pressure issues, and is more of a chance of having sudden cardiac death. So how do we treat acute coronary syndrome? Well, we can always use the mnemonic we known as MONA, okay? Now, so let's start off with M, being morphine. Morphine is a great pain reliever, but it also causes vasodilation, and it's going to decrease preload. So we're not going to have the heart work as much, and we're going to dilate those coronary arteries to feed the heart a little bit better. Now, you will get some pushback sometimes about using higher doses of morphine, because you don't want to mask the signs and symptoms, or the symptoms from your patient, of an MI. So you've got to use your lower doses of morphine. All right, so we're now talking about like 2 to 4 milligrams slow IV push over a couple of minutes. So what about O, role of oxygen? Okay, it used to be a long time ago, especially when I was started nursing 30 years ago, we always put oxygen on everybody because we want to help provide the heart and get the body very well oxygenated. The rule now per the American Heart Association is that as long as your O2 saturations are 94% or above, you do not have to utilize oxygen. But still consider that oxygen still may play a role in there to help decrease the work of the heart and help get that heart muscle oxygenated. Then we look at nitrates sort of as nitroglycerin. Well, it's a smooth muscle relaxant. It causes dilation. It decreases oxygen demand, so we want to do that. And then aspirin, we want to thin the blood. So now it used to be where we had to give 4 81 milligrams of aspirin by mouth, have the patient chew them up. The rule is now, as long as you can do 2 to 4, that is acceptable, and you want to get that aspirin on board. If your patient has already taken 2, there's nothing wrong to get them to take 2 more baby aspirins of 81 milligrams to give them a total of 324 milligrams of aspirin by mouth, because we want to start thinning that blood. But maybe we can help get that clot decreased, or help decrease that effect of decreasing the lumen of the coronary artery to feed the heart muscle. Now, antidiuretics are now starting to play a role. Do we need to start hanging amiodarone, which is very good, because lidocaine a lot of times is just sort of a temporary relief for ectopy. It works more just ventricular, where amiodarone is to be understood that it works very well with both atrial and ventricular ectopy. Now, beta blockers are playing a big role now, because now we say that instead of Mona, we've got Mona B. Because you think of what beta blockers actually do, okay? Because what happens, and I call it the blue light syndrome, what happens when a cop car pulls up behind you? Your heart rate goes up, you get vasoconstriction, you start retaining fluid. Well, do you want that to occur if your patient's having a heart attack? No, we want to slow things down. We don't want that heart beating very fast. We want that heart to be very efficient and pump blood out. I want to dilate. I don't want to retain fluid, okay? I don't want my heart to beat faster. So we're going to decrease heart rate. We're going to decrease water retention. We're going to decrease the amount of vasoconstriction that occurs. And we're just going to slow things down a little bit, step back, and let's get that heart to work a little bit better. As the rule, we always consider heart rate and blood pressure prior to administration. So if you've got a patient that's already got hypotensive, we've got a blood pressure that's less than 90 systolic, or a mean arterial pressure of less than 60, we do not want to do a beta blocker. If you've got a heart rate that's very less than 60, you do not want to use a beta blocker. So we're going to use caution with this, especially with patients that have right coronary artery occlusion, because they may already demonstrate this. So beta blockers would be contraindicated in administering to these patients. So what do we do next? Well, one, continuous cardiac rate and rhythm, because you've got to monitor the patient. You're providing therapy, so do you want to see the positive outcomes? Plus you want to monitor for negative issues that may occur. Monitor vital signs. Like I said, you want to see a trend. One set of vital signs is meaningless. So continuous blood pressure monitor, we're talking about like Q15-minute vital signs. Get the patient in a position of comfort. If they want to be in semi-Fowlers or sit up in a chair or high Fowlers on their stretcher, let them do so. And then watch the effects of your medication. If you're giving nitroglycerin, if you're giving morphine, what is it doing? Remember, nitroglycerin morphine can drop a blood pressure, all right? You want to assess all that therapy being provided, because you have assessed your patient, you've got a plan of care, you've now implemented that plan of care, and now you need to evaluate somehow. And is that through vital signs, patient demonstration, pain scales, what is the patient telling you, so forth. Also, be prepared to move your patient. If your patient is on a med-surg unit or a telemetry unit, they may require that higher level of care, so you need to start thinking about getting them to the next open available bed into a critical care unit. Keep in mind, though, this is where you may need somebody in the back of the room to be prepared to call a code blue or to get into that more deteriorating mode. So that may be setting up, getting a cardiologist there, pulling the crash cart at bedside, because you always want to be prepared, because we never know what our patients are going to end up doing. Now, PCI plays a very good role in treating STEMIs or acute MIs, because you have an occlusion. And it is the preferred, it's the gold standard there. But there is a time window, and it says that it should be done within 90 minutes. We call it door to balloon or door to wire time, and that should be within 60 minutes. The patient should be able to go from whatever point of area that they're in and to the cath lab. You need a place that can provide PCI, angioplasty, and stent placement. Okay, you need a chest pain center. So you want to start thinking about that early, rapid, get your patient stabilized and transferred. Because what we want to do is that we want to get the patient to the cath lab, because we have a coronary artery that is either totally occluded or so occluded that our patient's having chest pain and it's interfering with blood flow to the myocardium, and we are having issues with this, because we know that cell death of the myocardium is not going to be replaced with newer cells. Once that area dies, it dies, and we affect the function of our heart. Okay, and this is what we're doing when we go into the cardiac cath lab, is that they usually access the femoral artery, they're placing a catheter, and then they're going to float a wire up and get it down into the coronary artery, because the understand is you start getting blood down there and you start injecting dye, you can then therefore see the blood supply going down through there that has now been injected with some type of dye that can now be visualized on x-ray. Now this slide is the classic example. What we see here is a right coronary artery that has a mid-occlusion, basically a 99% occlusion. We can see the narrowing, see where the dye is being injected, it thins out, and then it proceeds right on down to near the apex and bifurcates in what we call the PDA and the PLA. So what we need to do is that there is a potential for this to totally occlude. So what has happened is that they've got a wire down and they ballooned that coronary artery, and now they have pushed that plaque up against the wall, and then in C pretty much they have already deployed what we call a stent, which looks like a very small spring and a pin, and they've pushed that plaque up against that wall, and now they've re-injected the dye, and now look at the blood flow. So now we've improved our cardiac, or restored good cardiac function to that area. This picture is one thing that will be done, and I like to show this because they will sometimes do this before or after the PCI, and it's called the left ventriculogram. And what they do is they inject dye into the left ventricle, and they're looking for movement or kinesis in there. And what they'll do is that if they see a wall that is not moving as well, like either the apex of the left ventricle or the most superior portion or down at the base, they can also determine which coronary artery is more of the culprit. Because if you've got two coronary arteries that are stenosed or clotting off, how do you know which one is actually causing the myocardial infarction? So sometimes this will be done to see what is not moving or not moving properly, and they will then consider whichever side as the culprit lesion. So for example, if the apex is not moving well, then they could say it was most likely the left anterior descending. Or if it's to your left on there, if you not see that wall moving very well or no movement, known as akinetic movement, then you could most likely say it is the right coronary artery that is causing that problem. So just to give you some further information, a little bit more detail, an LV-gram sometimes will be done to help paint a better picture as to what's going on with a stemming. Here is another way to look at that, and you can see which vessel sort of feeds from the left atrium, left ventricle when they do that LV-gram. Now, I want to talk about unstable tachycardia and supraventricular tachycardia, and we're going to talk about these based off the American Heart Association, and this can be an issue alone for rapid response. There are times that rapid response is called because the nurse calls and says, my patient has a heart rate of 130, or my patient has a heart rate of 180. So you need to have the rapid response team there, because number one, you've got to figure out first, is the patient stable or unstable with this heart rate being very fast? Because we know the heart doesn't function very fast or function very well when that heart is beating so fast. We're getting this nice quivering sort of going on. We haven't gotten to chaotic depolarization, which is ventricular fibrillation. We got a heart that's beating very fast. We're decreasing our filling time. And when that decrease of filling time occurs, then all of a sudden you get a decrease of cardiac output. Then you can get decrease of cardiac output, you get a drop in blood pressure, things do not perfuse as well. Guess what? Your patient can also have altered mental status. All right? So now your patient is unstable, okay? So the heart rate is too fast. All right? So unstable tachycardia is going to be that tachycardia that's 100 to about 149 or 150. Above 150, we say the patient has supraventricular tachycardia. That means supraventricular. That means above the ventricles, that heart rate initiated. There was something that occurred in the atrium, went down, the AV node did not play the red light like it's supposed to, and now it has gone into the ventricular areas and it is staying caught up with it. Okay? So the heart rate is so fast that cardiac output is reduced. So what happens? Patient can get pulmonary edema. They can have chest pain because cardiac output's dropped, so we're not perfusing the coronary arteries, and we have hypotension. That is a patient that is unstable. The heartbeat is ineffective in the atrium and the ventricles, or the ventricles alone. Therefore, again, we've got decreased cardiac output. So now we either have something going on in the atrium that is really fast up here, and it's really fast below. And a classic case of where you'll see a fast atrial beat versus a ventricular beat is your atrial flutter and atrial fib. But the AV node is doing what it's supposed to be doing. Where the concern is now where it's traveling down through the AV node, and like I said, the AV node is not playing stoplight. And now I'm interfering with my blood pressure and perfusion. So in supraventricular tachycardia, it is due to an AV nodal reentry. So when it starts up at the top, it should be this counterclockwise of coming down, going through the AV node, on down into your bundles down there to start for your electrical impulse. SA node, AV node, down to your bundles. And what's happening in supraventricular tachycardia basically is that it has now traveled up from the atrium, it is now into the ventricle. So now we got to figure out why is this patient in that. So what about signs of unstable tachycardia? Well, again, altered mental status. There's not enough blood supply to the brain, so the patient can't think. We're not feeding the brain. The brain's not getting oxygen, it's not getting glucose. Okay? There's signs of shock. What are signs of shock? Poor output, pale skin, poor capillary refill. All right? They're hypotensive. We've got blood pressures, what, 80 systolic, mean arterial pressures that are in the 40s versus in the 50s versus 60, 65, like where we want it to be. Patients having chest pain, like I explained before, because we're not feeding the coronary arteries. Blood pressure is low, we're not perfusing those three main coronary arteries. Heart failure. Everything's backing up. Do we have altered breath sounds? Are we now starting to get, hopefully we haven't gotten to the point that we're now having JVD and what I call cankles, or we get this big fluid overloaded ankles. So what to assess with a tachycardia? First, is your patient symptomatic? So you ask your patient, how do you feel? They may just say, I feel fine right now, but I can feel my heart racing. Okay, so now you've got time to sort of investigate a little bit more, and you've got time to play. You've got time to try non-invasive interventions, as I say. You look and see, is your patient stable versus unstable. You put them on the cardiac monitor, you get a full set of vital signs, you listen to breath sounds, you look for signs of shock. Then look at the rhythm. Is it regular versus irregular? Okay, is your patient in a monomorphic or a polymorphic VT? Your patient may be in a ventricular tachycardia but still have a pulse. What does that QRS look like? Is it narrow? Do you see everything? Or do you see a wide, strange complex? So these are things you're going to want to know. If your patient is asymptomatic and just feels a heart rate, get a 12-lead EKG, because that's going to give you a lot more information as well. So look here in lead 2, we have a patient that is in tachycardia or an SVT, and we can see we've got a little bit of a wide complex, but it's regular. R2Rs are pretty much regular here. So what we need to know is our patient symptomatic? Are they stable versus unstable? Okay, here we go. We've got another patient that's very tachycardia, but we can see this is very regular. Is this a patient that is an atrial fib that is now starting to develop in what we call rapid ventricular response? So you want to know this. We got a narrow complex. Here's a nice wide complex. It looks like a ventricular tachycardia. This is a patient that we're not really going to cardiovert. We got to be very careful. This is a patient that we're not going to do adenosine on. We've got to be careful with this because we may lose what we already have here. So what are we going to do? First, like I said before, always remember A, B's, and C's, airway, breathing, and circulation. Always optimize oxygenation and ventilation. So do I have good airway? Is my patient breathing? How's my blood pressure? Put them on some O2 if you need to because you've got a pulse ox on them. Get them on the cardiac monitor and get a 12-lead ECG. Go ahead and get an IV access because some of the medicines that you may need to do are going to need to be given intravenously. If your patient is stable and feels like they can feel the fast heart rate and you've got a good blood pressure, you've got time to do vasovagal maneuvers. Have your patient bear down, increase that intrathoracic cavity pressure, because when you do that, it decreases venous return, it decreases sometimes the cardiac output there, but it's going to work on that vasovagal nerve which comes off of cranial nerve 10. Now we may need to do adenosine. Okay, and adenosine, we're going to go to that 6 milligrams. You can repeat that with 12 milligrams IV and follow with another 12 milligrams IV per the algorithm, the latest algorithm per the American Heart Association under advanced cardiovascular life support. And you want to make sure you give it very fast because the half-life is very, very short. So you're going to follow this with a lot of saline. You're really going to be pushing this in fast and you're going to be following it with your saline as close as you can to the patient. Beta blockers may need to be used because, again, beta blockers block beta. They slow the heart rate down. Remember not code blue, but you remember the blue light syndrome. Makes your heart rate move fast. Okay? Calcium channel blockers, used a lot with our patients that are in atrial fib that have gone into rapid ventricular response because most of those patients will not respond to vasovagal or beta blockers. Okay, so when you got your 12 lead, you'll see where your patient, or if you know your patient's had atrial fib or has a history of it, and now they're in rapid ventricular response. Calcium channel blockers, Cardiazem, is the drug of choice here. When your patient needs to be cardioverted is when your patient is unstable. You don't have time to do vasovagal, because if your patient's unstable and is unable to mentate and follow commands, you cannot get them to vasovagal. You got a patient that's deteriorating rapidly, you have to go straight to cardioversion. Once things become under control, there may be an order for amiodarone, a bolus, and a drip. And again, like I said, amiodarone works very well both in atrial and ventricular chambers. Let's back up a little bit. Calcium channel blockers simply prevent the calcium from entering the cells of the heart. It's slowing that beat or that contraction down. So it does slow the heart rate down as well. It affects the electrical impulses as it passes from SA down through the AV node. So therefore we can control blood pressure, we can relieve chest pain because if our pump's much more efficient, and now we've got filling time during diastole, we can feed our coronary arteries. And then if we slow things down, then we most likely can control those irregular heart rhythms, those ectopies that we see on there. We sometimes refer to them as funny little beats. The other intervention for the tachycardia is the cardioversion. We can do with the narrow, regular, you're going to use about 50 to 100 joules, and this all comes per the latest of the ACLS standards. With narrow, complex, irregular rhythm, we're going to do about 120 to 200, so this is where you have your atrial fib. Amiodarone, you're going to give 150 milligrams over 10 minutes, then you do a maintenance infusion for the next 6 hours of 1 milligram per minute, and you should be able to set that up. A lot of infusion pumps or Alaris pumps, whatever your hospital system uses, it should be able to help you set that up in there. Now, what about shock as far as looking at patients? And I want to discuss shock because sometimes you may be called or your patient may be having signs and symptoms of shock. So what exactly is going on? Well, in shock, the circulatory supply of oxygen is not meeting the demands of vital organs. Okay, so there's not enough oxygen to meet the demands of what the body needs. And vital organs, you know, we got to consider the kidneys, the heart, and the brain pretty much. Okay, so there's this poor tissue perfusion that is occurring. So what is the body's going to do something? First of all, it's going to try to increase heart rate, because we know that if we increase heart rate, because what heart rate times stroke volume equals cardiac output. So if I increase my heart rate, my cardiac output's going to be better, my blood pressure's going to be better. Are we going to change stroke volume? What are we going to, is the body going to start pumping harder? Are we going to retain fluid? Because that's what happens when we have from the sympathetic system. We're going to retain the fluid to help keep our blood pressure up. Vascular smooth muscle tone changes. We're going to get more of a constriction in there. Okay? And we're going to retain fluid, because if we retain fluid, then our blood pressure is going to go up. So our body's already trying to compensate itself without our assistance externally. These are internal changes that the body's doing. Okay? Compensatory mechanisms. So we basically have 5 forms of shock. Okay? And they all can affect the preload and the afterload and the contractility. So it's hypervolemic shock. We get septic shock. Okay? Which we're learning much more about. There's many talks on that. We've got cardiogenic shock, we've got distributive shock, and we have obstructive shock. All right, so preload decrease occurs. Okay, so how can that happen? Well, in this form of shock and everything where the preloads decrease, we've got bleeding, we've got vomiting. In other words, there's not a lot of fluid that's sitting where it's supposed to be sitting to get pumped out throughout the heart. Okay, the patient is fluid volume deficit for some reason, and these are reasons of how a patient can become fluid volume deficit. All right, so what about afterload? We know this is systemic vascular resistance. When they're very decreased here, we've got profound hypertension. In other words, there's not a lot of blood that's sitting in there, okay? So sepsis is one of them, because now where is all the fluid? It's still in the body, but it's not in the circulatory system. Anaphylaxis, again, everything's dilated out, and the blood and the fluid has moved everywhere else but where it should be. Think of it as your gas tank is now empty, but there's gas all around it, but it's not serving the purpose. Spinal cord injuries and toxins, all these can do the same thing. In depressed myocardial contractility, which can give you a shock also, your MI, because if you've got damage to the myocardium, it's not going to pump as well. Dysrhythmias are going to cause a turbulent flow, so things aren't going to pump out as well. And cardiomyopathies, what about when the heart is so big? This is a muscle that does not improve as it becomes bigger. It becomes less efficient. And that's what we need to remember with cardiomyopathies. So consider compensated versus decompensated shock. In compensated shock, your patient's going to be tachycardic, they're going to have a much more good contractility, and they're going to have a good systemic vascular resistance. In decompensated shock, that's where you start noticing those capillary refills of greater than 5 seconds. Their blood pressure starts going down. Now we got a patient that's hovering with a mean arterial pressure like about 60, in their 50s. Systolic is like in low 90s. Okay? Metabolic acidosis now starts to occur, okay, because now we're not, if you don't have good circulation, that means oxygen's not getting in and CO2's not coming out. So now we're not getting good perfusion to areas, and now we're getting our patients heading towards an acidotic state. Uncompensated shock occurs late. It is the worsening of shock. It is now down to the cellular level. Now we have lactic acid buildup. We have gone from aerobic to anaerobic metabolism. We've gone from metabolism that is now no longer oxygenated. Okay? Hypotension is quite evident. Our patients' blood pressures are very low. You are now palpating blood pressures. Okay? You're not getting things by cuff. Your saturations are low because when you put the pulse ox on, there's not enough blood supply, and you're seeing your sats are now really low. So we're not perfusing there. So now we've got to have an oxygenation issue. We're going to see patients with changes in mental status because if the blood pressure is low, then I don't have enough pressure to get blood supply to my brain. So therefore, it's not getting oxygenated. So now your patient's now going to be confused. They're going to be tachypnic because now they're trying to compensate. If oxygen level is low in the body, like I said, the respiratory system is going to kick in. It wants to breathe faster to try to get oxygen delivered to where it needs to be done. Tachycardia also is a compensatory mechanism. It's trying to increase cardiac output. Hypovolemic shock, you're going to see the hypotension. You're going to see cool extremities. Why? Because now blood is now being pulled towards the vital organs. It's no longer worried about the extremities. So this is where sometimes that mottling starts occurring in the body. Of course, poor capillary refill. What about oliguria? Of course, your urine output's going to drop off. You put in a Foley and you hardly see any urine come out because the body's trying to hold on to the fluid. Plus, the other thing it's doing is you're not getting good perfusion to the kidneys, so therefore it's not getting rid of those toxins, it's not getting rid of the waste, so therefore urine output's not coming out. Dry mucous membranes. Again, you open up somebody's mouth, their lips are dry because now the body is trying to hold on to all of its fluid, plus you don't have good perfusion. So in septic shock, there are two phases that you need to think about, warm versus cold phase. Now in septic shock, and we know patients become septic, and there's many talks on sepsis and everything, but during septic shock, the patient starts off in a warm phase. Their blood pressure is a little soft. What I call those blood pressures like 100 over something, 90 to about 100 systolic. Okay, mean arterial pressures floating about 60. They're a little tachycardic because they're trying to keep the blood pressure up as part of a compensatory mechanism. Their skin color is good, and their arterial blood gases are good. They're able to oxygenate and they're able to ventilate. Now that window of the warm phase is anywhere from about 3 to 12 hours. Okay, and then the patient starts moving into the cold phase. Now the whole goal of septic shock is to keep the patient in the warm phase. This is why we do all those things during what we call when we start having a code sepsis or we think a patient's become septic. So in the cold phase, the patient is very quite hypotensive. Their mental status has changed. Their arterial blood gas look good. This is a patient now that's got respiratory acidosis. It's quite evident. pH has dropped, CO2 is climbing, and they're probably definitely showing their hypoxemia now. Their PaO2 could be about 60 or less. Okay, and the anion gap is now starting to widen out. Where it should be about 0 to 10, it has now gotten much wider when we start looking at anions and cations in those, and when we look at an anion gap. Okay. So in cardiogenic shock, Patients are going to have cool extremities. They're going to have a poor capillary refill time because now we have an issue with the heart, okay? So it's not pumping as well, so this is where we get cardiogenic shock. There's your clue. It's a heart issue. They're hypotensive. They're tachypnic. They have altered mental status. They have poor urine output, and now we understand why they have all this because there's poor pump. It's not working as well. Blood is not getting out of the heart like it's supposed to be. Why? That's what we've got to figure out why. We fix that, we don't get this, we improve and treat our cardiogenic shock. Now, distributive shock is what they call an acute insult. You can get it from anaphylaxis and sepsis. So there's that fine line with septic shock and distributive shock because they start mingling together. Profound hypotension and tachycardia occur. Vasodilation is the big issue. Now your gas tank is doubled in size, but you've not filled it up much more with gas, so now you don't get all that energy that you need. You've got to replace that. You get decreased venous return to the right side of the heart. So if the patient has a central venous line in, your CVPs are going to be low. Your mean arterial pressures are going to be low. Capillary permeability has become quite present. Now fluid is starting to leak from the capillary membrane into the interstitial areas. So fluid is on board, but it's not in the vascular space any longer. So now this is where it's become an issue. So therefore, stroke volume, cardiac output, and blood pressure all decrease. And therefore, this is why you get that shock state. In obstructive shock, there's an increase in afterload of the right ventricle. So think of afterload and preload again. All right, you got to keep that in mind too. So you've got a physical impairment that is affecting circulatory blood flow. Okay, do you have a cardiac tamponade, tension pneumothorax? All these lead to decreased cardiac output. So obstructive shock can occur from tension pneumothorax. So this is why I stated back earlier in this talk where tension pneumothorax is a true emergency. You've got to, because blood pressure is severely going to drop, you're not going to perfuse the major organs of the body, and you're going to have issues there, ischemia and infarct. Okay? Also consider a pulmonary embolus. All right? So you're going to get tachycardia again, heart rate's going to really jump up, tachypnic, patient's going to become breathing much faster, hypotension is evident, altered mental status again, and again there's your poor urinary output. So this is where it's nice when your patients have a urinary catheter in place. So what are we going to do about treating shock? Well, again, optimize your oxygenation and ventilation. Don't forget about those A, B's, and C's as I've been talking about. Aggressive fluid resuscitation, but not in cardiogenic shock, because what happens if we overflow the heart, we give it too much fluid, then it's got to work harder and things are going to back up. Then your patient's going to sort of drown in their lungs. We're going to see extensive JVD. All right? So now you look at treat the problem. Why did the patient become shocky in the first place? Is it an allergy reaction? Let's do that. Is it sepsis? Let's fix that. So we're going to start doing fluid boluses. Now, fluid boluses for people is about 20 to 30 mils per kilogram. We do about 20 mils per kilogram in our pediatric patients. We shoot more for about 30 mils per kilogram in our adults. So you're looking at a good 1 to 2 liters minimum in an adult patient that is shocking. All right? And you start considering inotropes. Okay? You don't want a chronotrope which increases heart rate. Think of chronograph, time, increase heart rate. You want an inotrope that's going to make that heart beat better and be more of a stroke volume is going to improve to increase our blood pressure. Then we can think about colloids, because crystalloids are going to be things like normal saline and lactate arena. Colloids are going to be albumin and blood products. In septic shock, we have to start thinking about antibiotic therapy because we want to start killing off that the bacteria that's in there, especially the gram-positives. That's why a lot of times we use vancomycin in there and Zosyn to get in there and start treating that. So therefore we can start treating it. So therefore we can hopefully prevent worsening of shock. Now I like to use the blender analogy. So you've got this wonderful blender and you want to start making your favorite beverage. And so you put in all your stuff and it just leaks out everywhere. So now blood or whatever your fluid has gone everywhere. That is hypovolemic shock. All of a sudden you've lost all your volume. In cardiogenic shock, you've got everything in your blender of your favorite drink and you go to turn it on and the motor's just not doing what it's supposed to be doing. Okay? So therefore, you've lost your pump. So now your motor's out. So that's a way to remember cardiogenic shock. So now you've got your blender's ready to go, you've checked it, the motor works good, you've got all your little stuff in there from your ice and strawberries or whatever your favorite drink is, and you decide to put your wooden spoon down in there, and now you've blocked your blade. So now you've got obstructive shock. So now you've got to remove that. So is that tamponade? Is it that tension pneumothorax? Distributive shock is pretty much you've got a leak everywhere, your motor's bad and your seal's bad. It's just affected everything. And in septic shock, your seal's broken and the glass is broken. Now you've got fluid everywhere where it's supposed to be. There's plenty of fluid all over the place, but it's not in your container. So I like to use the blender analogy. I use this a lot when I teach new nursing students. So remember with shock, give oxygen. Always remember oxygenation and ventilation is really good. Give fluids. You want to treat the cause and keep reassessing. Is what you're doing, is it working? Because if not, then you've got to figure out, do we do more fluid or have I diagnosed the right shock? So here is a patient scenario for you. I've got up here that Mr. J is a 56-year-old guy that's in the telemetry unit with new onset of chest pain while at work. He was found to be have hypertension. He's got a BMI of greater than 30. So this tells you this is sort of a large, a little bit overweight guy. And it didn't say that he had an MI at the time, but it was questionable on his EKG and some of his lab work that he had some ischemia. And when he lays still and he gets his sublingual nitroglycerins, his ECG improves and his chest pain improves. His first troponin was negative. So now I'm thinking maybe we got a little angina going on, maybe a little stable angina, because with rest he improved. And with some sublingual nitros, he's improved, okay? And that, like I said, his first cardiac marker is negative. So approximately 1,800 hours is what that should be. After having dinner, he starts having more chest pain. He's now, it's mid-sternal, it's non-radiating, he's now diaphoretic, he's got facial grimacing, he's known to be very anxious. Okay, so in this situation, we can already see that we've got a gentleman here that's already got a cardiac history. He's got some angina. Now, do we have unstable angina, or are we now having a STEMI or non-STEMI? So the first thing that we definitely need to do is make sure that we're oxygenating this guy. And we've got A, B, and C. And we want to do a 12-lead ECG, because that's going to determine, we're going to look for our ST elevation and we're going to start drawing labs, and we're going to get this guy in a position of comfort. This is now an emergency. So we can see why rapid response would be called on this patient. So what was the priority? Of course, like I said, oxygenation and a 12-lead ECG. Interventions, make sure he's got a good IV in, call rapid response. I want to check his pulses, I want to check his blood pressure, I want to listen to breath sounds, I want to assess his chest pain using the PQRST mnemonic. I can put him on pulse ox, I can put him on continuous cardiac monitor, would be my other assessment tools. And an appropriate plan would be for this guy to be moved to a floor where he can have continuous telemetry unit, or depending on what his ECG indicates, he may be a candidate for straight for the cardiac cath lab. So maybe additional things need to be done. Maybe all the rainbow of labs need to be done, and additional IV needs to be done, and getting in touch with that cardiologist. So a lot of it's going to depend on how he's presenting, what you are seeing, and what that 12-lead ECG is indicating to you.